most of the patients that we see second line who get a platinum doublet are bevacizumab naive because the FDA approval just happened in June 2018. So that means in that patient, second line is going to get a platinum doublet, and we've talked about the options. You're going to have to make a decision, bevacizumab or PARP. And I hope that's the decision. I hope it's not the decision, bevacizumab, PARP, or observation. I think if we've learned anything in the patient who's probably going to die, to say, go home, good luck, we'll check your C125 in 3 months, is not the way to treat our patients, as you say, in the paradigm that's evolved. And because maintenance therapy, as I said, is now efficacious, tolerable, and convenient. So how do you make that?
So can I just interject on that, and I think you know this data. This data is not published, but it's public. So I can say it, which is at present, the number of patients who are eligible for maintenance, who are actually getting it, is somewhere around 20 to 30%.
20, 30%.
It blows my mind.
It does to me.
And the NCCN guidelines seem to say you got 3 options. After responding to platinum second line, you got observation, Bev, or PARP. And again, all 3 PARP inhibitors are approved in that space, but there's no prioritization. And I'm here to tell you that there is a prioritization. And the prioritization, I'm not going to tell you Bev versus PARP, but I'm going to tell you Bev or PARP versus nothing.
Yeah, no, you're right.
That's right.
And so I think in terms of the decision making, as you just said, Brad, it's really making that decision up front. So it's making that decision, is she a Bev candidate or not?
How do you decide?
So you decide based upon, I think, the level of disease. So the issue around bevacizumab is that, yes, it prolongs progression-free survival, maybe OS a little bit in 213, but the overall response rate is going to be higher. So if that patient is more symptomatic, but on the other hand, not quite yet symptomatic enough to have a bowel obstruction or kind of an impending bowel obstruction, I would certainly think about her for bevacizumab. Because you need a response now.
So let me address that. At this meeting at the ESMO 2018, the new ESMO ovarian cancer guidelines were launched, and it's exactly what you said. And they're trying, they recognize that observation is a bad idea, but they say in the more symptomatic patient that the triaging to Bev is preferred. I like that, and that's what the guidelines have said.
Yeah, well, that's certainly true for ascites and issues like
Yes,
that.
that's the whole point.
What I find interesting about this discussion, and it applied to frontline also, I think, to a certain extent, which is that the sort of hesitation to use Bev because it's only PFS versus OS, not different than PARPs. There's not a lot of OS data in PARPs that I can.
Not yet. We don't have any. We have no OS.
More impressive.
Right, but we have OS. We do have that data available for bevacizumab. We don't have that data yet for PARP inhibitors.